Hello everyone, welcome to our video on cataracts. So just before we begin, I want to go over the basic anatomy of the eye really quickly so we all have our bearings before starting this video. So here's a picture of the whole eye. What we're going to focus on today is the front of the eye. So zooming into that here, you can see some of the structures labeled. The most important one for the pathology of cataracts, and so the most important one for this video, is going to be the lens right here. It's this clear structure that sits right behind the iris. So what exactly is a cataract? A cataract is a clouding and hardening of the lens that leads to blurring of vision. So what that means, if we look at some diagrams, if you look at the diagram on the top, this is what an eye looks like with a normal lens. As you can see, the light comes in, it hits the lens is able to refract that light to give a crisp image on the retina. If you have a cataract, what'll happen is that light will come in, it'll hit the cataract lens, and it'll kind of scatter everywhere because it's clouded and it's hard. So you won't get a crisp image on your retina, and then you will complain about blurry vision. So a cataract has different morphologies and subtypes. And what I mean by that is that the lens itself has different layers to it. It's not just one homogeneous structure. What a lot of people like to compare it to is a peanut M&M. So just like a peanut M&M has a peanut on the very inside of it, which is surrounded by a chocolate layer, which is surrounded by a candy shell. A lens also has similar structures. It has a nucleus in the middle, a cortex, so the chocolate surrounding that, and then the capsule surrounding that. The most common type of cataract is a nuclear cataract. It's associated with aging. There are other types you can get as well. So who gets cataracts? The simple answer is if you live long enough, everyone will. So the prevalence of it is most common in older populations. The pathophysiology of cataract formation can actually be thought of as just a normal aging consequence. So if you live long enough, you will get cataracts. There are things that can accelerate that process, and some of the risk factors I've included here. There are also cataracts you can get congenitally, and most commonly those are from torch infections, which are these things right here if you don't remember what they are. You can also get them from some other things less commonly as well. So what are the clinical features of cataracts? So patients will complain of blurry vision, obviously, but also that is the main complaint in most patients coming to eye clinics. So how can you differentiate the history of someone who comes in for cataracts versus something else? There are some characteristic findings that patients will complain of. Most commonly, they'll complain of darkened vision at baseline, but they'll complain that lights become too bright at night. And specifically, they'll complain about concentrated sources of light being too bright. And when they're too bright, they'll have glares or they'll have halos. So headlights, for example, is a concentrated source of light that might produce these effects. So someone with a cataract, for example, who's driving at night might see something like this, and they'll complain of something that looks like this. And that should hint you towards a cataract. They'll also complain of some difficulty differentiating colors. As we get older and that lens gets harder and cloudy, it also commonly gets a yellow tint to it. And so that'll make colors less vibrant, and it'll also lead to that difficulty differentiating colors. And then another important thing to remember about cataracts is it's a painless process, and often it's bilateral. So how do you diagnose it? Most commonly, you can just diagnose it with a slit lamp, and it can be super obvious. Like if you sit down at a slit lamp, you turn it on, you see the patient's eye looks like this, you immediately know it's a cataract. It's a very obvious opacity right behind the iris of this individual. So it's a cataract. You can take them directly to the next step, which is surgery. You can also support your diagnosis by other things. So there's things like brightness acuity testing. This isn't done as much as the slit lamp, obviously, but what you would do with this is you put this contraption in front of the patient's eye. It shines a light into their eye, and you ask them to read the Snellen chart just like normal. But because the light is shining into their eye, and because they're affected by this light more than a patient would be if they didn't have cataracts, their visual acuity is going to go down. And again, the reason that happens is because the light that's coming in constricts the pupil. It worsens the blockage by the cataract. You can also do a test of a red reflex. And so a normal red reflex, if you look at this child's eye, when you shine a light into the eye, it'll go all the way through the normal clear lens, and it'll bounce off the retina, which is red, and you can see it just like in this eye. But if you have a cataract, the light will shine into the eye, but it'll get blocked by the opacity of the lens. So you won't be able to see the reflection off the retina. You'll just see the reflection off the cataract. There are some other things too that can lead to the absence of a red reflex. It doesn't automatically mean that the patient has a cataract. Like a retinoblastoma, for example, which is a tumor at the back of the eye on the retina. It's white, And so kind of if you look at this baby's other eye, if you shine a light into it, you won't see the normal red reflex off the retina. You'll see the light bouncing off the retinoblastoma, which is white. And so this is an example of like an absent red reflex that you get from something that's not a cataract. So the treatment for a cataract is always surgical. There's no pill, there's no medication that you can take to magically make it go away. You have to go to surgery. The surgery is phacoemulsification. And so if you look at this diagram here, you can see that the surgeon will stick a phaco probe in there, and the phaco probe will liquefy and aspirate the lens. And specifically, kind of like what we talked about earlier, it'll aspirate the nucleus and the cortex. It'll leave the capsule. So you're taking out the peanut of the peanut M&M and you're taking out the chocolate, but you're leaving the candy shell. And the reason for that, the reason you leave the candy shell is so you can put a new artificial lens into it. And this is obviously clear, very clear compared to the old cataract. And so the patient will be able to see much better after the surgery. There are other things you can do as well aside from phacoemulsification, but these aren't really done anymore. It's mostly just phaco. I've just included these for completeness sake. So a summary of what we've talked about today. A cataract is opacification of the lens that leads to blurring of vision. Most commonly, it's an acquired disease that comes with age. You can also get it from congenital things as well. We've talked about some of the risk factors that can make it worse or lead to acceleration of the disease. Some of the clinical features of it includes like painless decreasing visual acuity associated with seeing glares and halos around lights, as well as dimming of colors. The diagnosis is clinical, and often it relies on subjective evaluation of lens opacity seen on slit lamp examination. And the treatment for it is always surgical. There's no pill you can take, and it requires replacement of the old lens with a new artificial lens. That is all I had for cataracts. Thank you guys for watching, and I hope this was helpful.